Okay, this is the continuation of Chapter 9, dealing with muscles and muscle tissues. Different factors that are involved with muscle contraction. When you look at the force that the muscle contracts with, it's dependent upon the number of cross bridges that are attached. And this is influenced by the number of muscle fibers that were stimulated. The more motor units that are stimulated, the greater the force is going to be. What is the relative size of the fibers? The bulkier the muscle, the more tension it can develop. Frequency of stimulation, so the higher the frequency, the greater the force is going to be, because often stimuli are added together. And the degree of muscle stretch. Muscle fibers with sarcomeres that are anywhere between 80 to 100% of their normal resting force will generate more force. If it's less than 80% of the resting length, the filaments are overlapping too much and that force starts to decrease. If the sarcomere is greater than 120% of the resting length, then the filaments don't overlap enough, so the force decreases. So ideally, you want it between 80 to 120%. So this is just showing the contractile force that the more cross bridges are allowed, you get higher strength in. Excuse me. And this is showing what we were just saying, that 80 to 120% is the optimum length. For the reasons we just mentioned, it's too high or too low, you don't get as high a strength. How fast a muscle contracts and how long it can stay contracted is going to be influenced by the muscle fiber type, the load, and the recruitment. With muscle fiber types, we have two different ways of classifying, two characteristics to look at. The speed of contraction, either slow or fast. It basically has to do with how fast does the ATPase split that ATP. Metabolic pathways is the other way of classifying it, so the speed and then the pathways. Oxidative fibers, which uses aerobic pathways, versus glycolytic fibers, which use anaerobic glycolysis. So you can classify skeletal muscles as being slow oxidative, fast oxidative, or fast glycolytic fibers. This is one of those three. Most of your muscles are going to have a combination of these fiber types, and genetics will determine the percentage of them. So different muscle types are better suited for different jobs, as you might be able to figure that out. Slow oxidative fibers are very good for low intensity but high endurance activities, like maintaining your posture. It doesn't take a lot of force, but you've got to be able to contract for long periods of time. Fast oxidative fibers are for medium intensity activities like walking, sprinting. Fast glycolytic fibers are good for very short-term, very intense, very powerful type movement. Kicking a ball, throwing a football, hitting a baseball, something where you need a lot of strength right now. And so we look at some of these different factors that will influence the velocity and the duration of skeletal muscles. Do you have predominantly fast glycolytic, which are going to fatigue fairly quickly, versus predominantly slow oxidative, which will have high endurance? And this table will give a comparison of some of the characteristics between these three different types of fibers, of the slow oxidative, the fast oxidative versus a fast glycolytic. What are the things that you're looking about? The myoglobulin, remember that's what binds oxygen. And the structural characteristics as far as how many mitochondria do they have. Capillaries. Load and recruitment. Load refers to muscles that contract fastest when there is no load that's added. The greater the load, the shorter the duration is going to be. The greater the load, the slower the contraction is going to be. Recruitment deals with the more motor units contracting, the faster and more prolonged the contraction is going to be. And that is shown here. in a graph. How do you adapt to exercise? Well, aerobic exercise or endurance exercising, things such as jogging, swimming, biking, it's going to lead to more muscle capillaries, it's number of mitochondria, and the myoglobulin, myoglobulin binds the oxygen. So it's going to basically result with increased endurance, increased strength, increased resistance to fatigue. Some of the fibers may convert from fast glycolytic to fast oxidative. Resistance exercise typically is more anaerobic in nature. Things such as weightlifting, you intend to increase the size of the fiber. So you get muscle hypertrophy where you're increasing the size over all of the muscles. You increase the mitochondria and the myofilaments, glycogen stores, which is a storage form for glucose, and the connective tissue. So you get that increased muscle size, increased muscle strength in there. Now, muscles need to be active to remain healthy. If you're not using them, they tend to atrophy, which is the loss of mass, and they start to degenerate. This is due, when muscles atrophy, it's due to them not being used, the immobilization of them. There's no neural stimulation. It can start to begin immediately. Muscle strength can decline about 5% per day. Someone who is paralyzed, those muscles may atrophy to about 1/4 their normal size. Fibrous connective tissue tends to replace the lost muscle tissue. At that point, to try to rehabilitate is difficult because you can't replace the muscle. Making these slides during the time of the pandemic, some people have noticed while being in quarantine that their lifestyle has changed. They may not be exercising as much as they used to. And they're like, oh, I'm feeling lazy. You need to remember, as difficult as it is, there's lots of ways of exercising at home. So try not to spend too many hours just sitting on the couch watching TV. Try to remain active, do things, because you don't want your muscles to start to atrophy. Most of the emphasis in part 1 dealt all with skeletal muscle. Now we're going to move to a little bit to talk about smooth muscle. Smooth muscle is found in the walls of most of your hollow organs, except for the heart. The heart has cardiac muscle. So your stomach, a lot of your digestive organs, your blood vessels, etc., all have smooth muscle. And remember, they're involuntary. They're spindle-shaped fibers. They only have one nucleus. When you look at them microscopically, there are no striations. They don't have those connective sheaths. They only contain the endomyosin. With your organs that do have smooth muscles, typically you have layers of them. You have at least 2 layers of them. And the fibers are organized so that the sheets of fibers are going in opposite directions. That makes it stronger. So you have longitudinal fibers, this layer where the fibers, they're going parallel to the long axis. When they contract, the particular organ that you're looking at is going to shorten. Then there's also a layer that's what's called the circular layer. And as the name implies, the fibers run around the circumference of the organ. Because remember, in the middle is it's a hollow, and that's what we call the lumen. The lumen is that hollow area. And so the circular layer causes that opening to constrict. It allows for a process that we call peristalsis. Peristalsis is alternating contractions and relaxations. And say if you're looking at the stomach, it allows for better mixing of the substances that are in the lumen, in that open area of it. So if you look at showing in the digestive system, specifically in the small intestines, you have your longitudinal layer, which is right here, the outermost one. So the fibers are running this way. And then you can see here, the innermost layer is the circular layer. So as these two contract, you get much better mixing that way. Now with smooth muscle, there's no neuromuscular junction like what we saw with the skeletal muscle. Instead, you're going to have autonomic nerve fibers. Autonomic nerve fibers are part of the autonomic nervous system, which is involuntary, so you don't have any control over it. Those will be the nerves that are going to innervate, meaning stimulate the smooth muscle. They contain what are known as varicosities. These are little swellings of the nerve fibers, and that is where the neurotransmitter is going to be stored and then released from there. So I think you can see a little bit better here. Here are these little swellings, those are the varicosities. So that's where the neuromuscular, the neurotransmitter is going to be stored, and it'll be released from here, like what we saw at the neuromuscular junction with the nerve and muscle, skeletal muscle. But this wraps around, and that's how it's going to be innervated. The smooth muscle also does not contain sarcomeres, myofibrils, or T-tibials. The sarcoplasmic reticulum is much less developed. The sarcoplasmic reticulum does store intracellular calcium, but most of the calcium that is going to be needed for contraction to occur is going to come extracellularly. So you're going to have these little infoldings called the caduculi. They are going to contain calcium channels. So you're going to have an influx of calcium coming in. So right here are these little channels. And so instead of having calcium stored in the sarcoplasmic reticulum, it is going to be dependent upon these channels opening up and allowing calcium that's extracellular. Remember, I've always said it's higher concentration outside the cell to flow in to allow for the contraction to occur. The thick filaments are much fewer in smooth muscle than you saw in the skeletal muscle. And there's no troponin complex. It does have tropomyosin, but no troponin. There is a protein that binds to calcium, so there's no troponin to bind to calcium for smooth muscle. Instead, you have this protein, calmodulin. So your thick and thin filaments are arranged differently. They are arranged diagonally. During contraction, you're going to have what we call these dense bodies. These are proteins that anchor the filaments to the sarcolemma, kind of like the Z disc. And so during contraction, the sarcolemma between these dense bodies is going to bulge outward, so it looks real poofy. So this is showing a contracted muscle. So this is going to look real kind of poofy here. Here are your dense bodies. And the muscle's going to contract inward this way. So this is showing comparison, once again, of your skeletal, cardiac, and smooth muscle. Once again, that smooth muscle has no striations to it. It is involuntary, just like cardiac. It does not have the T-tibials. There are gap junctions, those pores from one cell to adjacent cells that fluid can move through. It is regulated by the autonomic nervous system. It can be regulated also by or influenced by hormones. It is sometimes influenced also by stretching. The source of calcium is going to be somewhat from the sarcoplasmic reticulum, but mostly from extracellular fluid. And then here you can see is the calmodulin that's going to bind to the calcium. The speed of contraction typically is very slow. It is very rhythmic. It can respond to stretch. It is going to be mostly aerobic. So the contractions, like I say, are very slow. They're synchronized. Those gap junctions, those little pores or openings from adjacent cells, does allow for the action potential to be transmitted from one cell to another, from one muscle fiber to another. There are some cells that are what we call self-excitatory. They act as pacemakers. So they can help with the rate and the intensity of the contraction to help modify that. There is a sliding filament mechanism, like the final trigger is going to be increasing that intracellular calcium level. Where is it coming from? Extracellular, you open gates to allow it in. Contraction is going to stop when calcium is no longer available and ATP is required for contraction to occur. Just know, once again, you have a different protein. It is not troponin that we saw in the skeletal muscle. I want you to focus mostly on the skeletal muscle, the steps for contraction, and then just be aware of some of the differences between skeletal and smooth muscle contraction. And this is showing the sequence of the steps where you have the influx of the calcium. It's going to bind to the modulin, which is going to then activate it. And you, once again, get your myosin heads binding to the thin filaments. Visceral muscle. This is found, the unitary smooth muscle, found in all hollow organs except for the heart. So when you see visceral, think smooth muscle. Some of the common characteristics, once again, is that the muscle is arranged in sheets, longitudinal versus circular. It's innervated by the varicosities. It does often exhibit those spontaneous action potentials. You do have the gap junctions, which allow it to pass from one cell to adjacent cells. It can respond to various chemical stimuli, meaning the hormones like that. It's stretching. Multi-unit smooth muscles located in the large airways, such as in your lungs, your larger arteries, the iris of the iris in your eye that gives the color, that is smooth muscle. Some of those have very few gap junctions. Muscular dystrophy. This there's different types of muscular dystrophy. It is an inherited disease. Usually it's seen in childhood. The muscles tend to enlarge because you have fat deposits and connective tissue deposits, but then the muscles start to atrophy and then degenerate. Duchenne's muscular dystrophy is the most common type, and it is the most severe type. It's inherited. It is a sex-linked trait, meaning it's often carried by females. So a female may not have the disease, but she is a carrier. So you have, she passes it on to her son on the X chromosome. Because males only have one X chromosome, they have a higher chance of getting it versus females. Victims, basically what you start to see, because the muscles are atrophying, they can't use them as well, they become more clumsy, they tend to fall frequently. Usually it appears between ages of 2 and 7. There's currently no cure. There are some medicine that can help improve muscle strength, help improve the function. They've tried different therapies, but right now there is no cure for it. They are looking at gene therapy and infusion of stem cells. Unfortunately, most of the patients do end up dying of respiratory failure in their early 20s. And you might think, well, why respiratory failures? Because in order for you to inhale and exhale, it is dependent upon a lot of the skeletal muscles in the thoracic area as well as the diaphragm. So if those muscles are not able to contract, you're not able to inhale, or they're not as efficient at contracting, you're not able to inhale as efficiently, and that's going to lead to respiratory failure.